and they stay for a week, 2 weeks. Maybe they even stay a little bit longer than that. But they eventually pick up all their toys and go home, don't they? And the community then is left. And here's the biggie then that becomes a problem, is the follow-up care. Now, we have a responsibility to provide follow-up care for something that has occurred, perhaps through relief aid, that requires services, requires attention, requires healthcare skills that perhaps we're not even ready to deliver. How are we going to do that? How are we going to interact and collaborate with other organizations to make sure that somebody knows how to take care of a patient following an amputation, and that they're going to be able to be rehabilitated and be brought back into the society? Now that falls on our shoulders as healthcare people, and how prepared are we to deal with this afterwards during the recovery phase? And then I think a very important part is that we have a voice as healthcare people to advocate for vulnerable populations, to advocate for adequate follow-up care, to advocate for good health promotion and preventive techniques. We are the people who see it, who deal with it, and we need to be advocating for victims as well as for ourselves in this period. It's difficult to advocate during the relief phase period, but during the recovery phase period definitely is the time to do that, to take on that role. And then as we move along into the development phase, the important one is for us to be able to do an adequate community assessment, and for us it would be focusing on healthcare needs. What are the healthcare needs now? Have they changed? Or are they not any better? And can we make them better so that next time around we won't have quite so much damage, we won't sustain quite so much damage to the population? And that involves community education, bringing the community in, bringing the families in, bringing the children in, bringing the mothers in to learn first aid. Here's what you do. Here's who you contact. How about students? As students, is there a role for students in the healthcare cycle and disaster? And there have been a number of studies that have looked at this and looked at both medical students and nursing students and how and if they can play a role. And certainly there's always the issue that the fact that they're not licensed yet and they lack a license to practice. But under supervision can be very useful, and particularly when brought together ahead of time and with a minimal amount of training, can be prepared to help while still a student in a healthcare profession. Students have been used, medical students and nursing students have been used to man and staff emergency hotlines. They know how to do it, they've been oriented to the system, and they are able to do that. They can work in immunization centers, whether they may not give you the immunization, but they certainly can bring patients in, they can keep records. Record keeping is essential at this time, and they can be involved in helping in immunization centers. They also certainly can provide any clinical and administrative assistance that they're capable of, and just be there as an extra hand in a setting, a clinical setting, that they may feel comfortable in. They can provide support in terms of communications and logistics. You might be designated to be in a hospital or a clinic or a place where the communication systems have gone out entirely, and there's no telephone, and no one ward has the ability to communicate with another ward. No one knows how to, they can be used as runners. Here's the messenger. Go here. Tell them this. Bring back this information to me. Go to the emergency room. Tell them I need this information. Bring it back to me. So it's a big role, and it's an essential role, and runners are very useful in this type of setting. Sometimes runners with walkie-talkies even, so that they can really relay information quickly, because communication systems will be gone. They also can support at shelters and family information centers, perhaps helping in terms of just being there while people are there looking for loved ones. You perhaps can help set up a wall of photographs. You can help in numerous ways just to support the victims and the staff at shelters and family information centers. Certainly they can be very effective as just patient transports. Take this patient out of this unit over here. I need this bed. Somebody's coming in. So utilization of students has been very useful there. They can help in the basic setup of care camps, working under the direction and supervision of other healthcare personnel. They certainly can help erect and set up a camp and camp equipment. And they can also help with safety and security, working with the system of safety and security. They can help man doors to keep inappropriate people away. That becomes a huge problem at the hospital at the time of a disaster, is keeping the doors open for the people who need it versus the people who don't need it. So not necessarily being involved in triage, but just being a body there to help secure, to help to know when help is or further assistance is needed. So now I want to talk a little bit about disaster education and what that is about, where we're going with it, how does it fit in to our study system and our educational system. And first of all, I'll say in 2003, so this goes back after the events in 2001 in the U.S., the Association for the American Medical Colleges, who is responsible for all the medical schools in America, made a recommendation that all accredited medical schools include, they call it bioterrorism preparedness, which was really a disaster, a specific disaster. Instead of an all hazards approach, they call it, they were referring and responding to 2011. So they called it bioterrorism. So all medical schools are supposed to at this time have some inclusion of disaster medicine in their curriculum. In a recent survey, it was really found that only about a third of them, probably slightly less than a third of them, do include any disaster medicine course in their curriculum. And of those, it was an elective in several. It was a required course in about 21%. So one course in disaster medicine in medical schools, and it was only in less than about 21% had to take that course. The courses that are most commonly offered are courses related to pandemic influenza and SARS, and community and hospital hazard planning. Seems a little strange to be offering to a medical student how to plan for in their community and hospital, but those are the courses currently that are offered, and of course they relate more to the scene in the U.S. and the potential hazards that we face, and we're certainly very much concerned about pandemic influenza and SARS, and so working within a particular type of event, they work through the disaster cycle in those courses in some medical schools, generally in about the fourth year of medical school. Sometimes some get offered in the third year. It's usually only by about the fourth year that they have any disaster education. In terms of nursing, The American Nurses Association has also recommended that disaster preparedness be part of the undergraduate nursing curriculum. There should be some component of disaster preparedness in the curriculum. However, like the medical schools, I can tell you few schools are compliant with that. And there are a number of reasons for that. One is, of course, already, as you're aware, your curriculum is already jam-packed full. It's hard to find room for any other additional courses or topics. The other is that it's very difficult in many schools to find appropriate people to teach it. People who have the knowledge and the experience. And not everybody does. But that's another limiting factor. But probably time is the huge one. Even though, of course, in our country, and I know in many countries, we've been mandated by our government to develop our health workforce to meet the needs of a disaster. We've been told we need to have a workforce ready to respond. And yet, in truth, the reality is, if few schools really offer it, how on earth are you going to get educated in disasters? They don't occur very often. Thank heavens. Well, one way, of course, in our country anyway, that we have numerous master-level programs in disaster health, where the focus is entirely on disasters, and certainly public health schools also include disaster health as their part of their population health, public health program. There are numerous programs that have sprung up, certainly in the U.S. There are many around the world, too, that have a master's prepared programs. What do these programs teach, though, is something that's a little bit unknown, and it pretty much covers a broad range of issues and topics. But the big approach today is competency-based education. And the reason competency-based education works in terms of disaster preparedness particularly is that we already are educated as professionals by the time we pursue studying disasters. We have a professional degree. We have a baseline knowledge of function and operation and theory and skills. What we need to know is how to improve our working in that area, how to improve our workforce. And competencies are very good at that because it's an approach in which the learner has to know how and be able to do something in a complex working situation. It was a whole movement that started in the U.S. in the 80s, and it came out from the fact that the complaint was made by industry, by corporations, by businesses that college graduates coming to work for them had 4 years of education and didn't know how to do anything. And so from that became the growth of competency-based. Now you not only need to know the theory and the knowledge, but you need to know, if you want to function in the real world, you need to know how to do something. And that's what competency is about, how to do something in a function in our complex working situation. So it teaches a specific capability. It's a combination of skills, abilities, and knowledge, but asking you to perform a specific task. It's always related to doing something. In terms of disasters, the challenges that face disaster, particularly disaster healthcare competency I'm talking about, is that, number one, disasters occur really infrequently. So it's hard to maintain a skill. When I say I haven't done an IV in a couple of years, that's hard for me to maintain that skill when I don't do them. If you don't have a disaster occurring often, keeping up on a skill you need can be difficult. And disaster